You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 15th, 2023. Our topic is allergic diseases during pregnancy, presented by Dr. Jennifer Namazy from the Scripps Clinic in San Diego, California. She is the chair of the Women's Allergy and Immunology Committee for the Quad AI and represents the Quad AI for vaccines and medications during pregnancy. This is Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 15th, and today we will be talking about allergic diseases during pregnancy. We have Dr. Jennifer Namazy here today. She's an allergist who practices at the Scripps Clinic in San Diego, California. Her research interests are in the management of asthma during pregnancy. She is currently the RSLAAIS Governor for California and Hawaii, the chair for the Women's AI Committee at the Quad AI, and represents the Quad AI for the vaccines and medications during pregnancy surveillance study. All right, thank you for joining us today.
Yeah, thank you for having me. To discuss. So basically, we're going to spend quite a bit of time in asthma, but we're also going to hit some of the other allergic diseases that are commonly seen in our non-pregnant patients as well as our pregnant patients. So next slide. So for each condition, we'll also look at potential maternal and fetal consequences of uncontrolled symptoms and review what's available in terms of safety data, as well as more practical medication recommendations during pregnancy. Next slide. So in terms of prevalence, allergic diseases affect anywhere from 18 to 30% of childbearing aged women. And in the United States, 5 to 8% of pregnant women have asthma. And we know that the prevalence is increasing over time. I think it's important to note that asthma exacerbations range anywhere from 13 to 50% during pregnancy. So it's an important condition that can commonly affect pregnant women. Next slide. Why it's important is that it can increase the risk of perinatal complications to both mother and baby. And we also know that when we manage asthma during pregnancy in a more kind of global, like a whole management sort of situation, I'll get a little bit more into that, but optimal management during pregnancy for asthma really does lead to better outcomes. Next slide. So we used to say that a third of pregnant patients with asthma have their symptoms get worse during pregnancy, a third have their symptoms get better, and a third have their symptoms stay the same. But from kind of more recent data, that this may not be as accurate as we once thought. One cohort study in the US that was recently published found that actually 40% have their symptoms get worse, and no one really gets better during pregnancy. So it either stays the same or it gets worse. So when you're taking care of a pregnant asthmatic, you're looking for risk factors for uncontrolled asthma during pregnancy. And there's some kind of some that should be highlighted that you really just look for, which is poor adherence. Are they not really taking their medications regularly? Are they entering pregnancy with poor lung function? And are they having severe symptoms or severe asthma or exacerbations prior to pregnancy that kind of leads you to think that maybe their asthma is going to continue to worsen during pregnancy? And obviously having other kind of risk factors, including smoking and obesity, can lead to more exacerbations during pregnancy as well. Next slide. So these are the outcomes that have been associated with uncontrolled asthma and severe asthma. So uncontrolled asthma can lead to outcomes such as preterm birth, preeclampsia, malformations, intrauterine growth restriction, and obviously what we absolutely the worst case scenario is mortality. Severe asthma can lead to other similar complications, but as well as hemorrhage and placenta previa. Next slide. We were part of this meta-analysis it's about 10 years ago, which really looked at the effect of asthma on pregnancy in studies leading as far back as the 70s, and really found that supported that having asthma during pregnancy puts you at an increased risk of both maternal and fetal adverse outcomes. Next slide. So what can we do? What are the components or what are really the foundations of therapy of managing these pregnant asthmatics? I mean, obviously you want to control symptoms, and that can include the reduction of triggers, whether it be smoking or allergens for allergic asthma. You want to prevent asthma attacks, obviously, and that really includes educating patients and educating ourselves, because as physicians taking care of these patients, there are multiple reports of undertreatment, whether it be by emergency room physicians, OBs, allergists, pulmonologists. We are all at risk of undertreating these patients. So that is very important. And then educating patients on the importance of adherence, because that is probably one of the most important conversations you'll have with a patient because of the fear of medications on their unborn baby. And then obviously preserving normal lung function using available medications. Next slide. So the importance of management. So a recent survey showed that over a third of pregnant women did not have their asthma reviewed during their pregnancy. About a third had a written asthma plan. So 70% did not have a written asthma plan. 11% had their lung function assessed during pregnancy. Over a third had their inhaler technique reviewed. 65% were not questioned about their asthma symptoms, and 95% didn't receive smoking cessation information. So we do have a lot of work that we need to do on our end as well. This is a study that came, new slide, sorry. This is a study that came out of Australia that really highlights the importance of a multidisciplinary approach to managing asthma. This was a pharmacist-led intervention in interaction with a family physician, and really kind of, again, coming back to this kind of global management of a patient, assessed asthma education, trigger avoidance, smoking cessation, and then monthly monitoring of FEV1, the rate of exacerbations, their medication use, and reviewing action plans with the patient. And they found that by 6 months, the mean ACQ had significantly reduced in the intervention group versus the group that just had normal care that didn't include these types of interventions. And so this works. And that was part of the reason this year we had rolled out the Breathe for Baby toolkit. So this is available on the Quad AI website. If you just type in Breathe for Baby toolkit, this will pop up, not necessarily this asthma plan, but a lot of educational material that you can download for yourself as well as your patients in regards to the safety of commonly used medications, biologics, and their safety data that's available now. That's in a handy kind of printable form. But really the cornerstone of the Breathe for Baby toolkit is the new pregnancy and lactation asthma action plan. So we created this and this is along with AFA that we are kind of rolling this out. But you know, the action plan is not too different than a non-pregnant asthmatic action plan. There's a little more detail. So we have an area for asthma checkup visits, any vaccinations, biophysical profiles, and then symptoms that may be a little bit more unique in this population of patients, such as fetal movements, vaginal bleeding, headache, vomiting. So this was kind of created with the sense of a multidisciplinary approach because it's a hard copy that can travel with the patient and go to other people taking care of them, such as obstetricians. And this can kind of evolve during pregnancy as well and be something that also gives the patient ownership over kind of their care. The other thing, next slide, that came out that is available in the Breathe for Baby toolkit, as well as the pregnancy asthma control test, which has been validated back in 2016. It was published in the JCI. Again, not too different than the non-pregnant asthma control test, with some slight differences. You can see in question 2, how often did you have shortness of breath due to your asthma? Because we know that dyspnea during pregnancy can be a very important thing that you have to delineate during pregnancy as well. Next slide. So we're going to kind of dive into some of the specific asthma medicines that we use and available safety data. Next slide. Before we get into that, though, I want you to kind of think about where we're getting a lot of this information from. I mean, obviously, randomized controlled trials are a gold standard, but are rarely done in a pregnant group of patients. So we tend to rely on these types of studies: prospective cohorts, retrospective cohorts, and case controls. And they all have their advantages and disadvantages. The prospective cohort has the advantage that it captures potential confounders. And these patients are followed over time. So one of the disadvantages is that sometimes you don't see a lot of outcomes because they're so well managed. But because they're smaller, they lack the power for specific birth defects, which is important. Now, on the flip side of that is the retrospective cohort, which has the advantage of having an extremely large sample size. So you really can capture multiple outcomes, and it tends to be population-based. But again, these outcomes are usually based on the medical record and dispensations of medications, but which may not be necessarily actual exposures. So there are disadvantages and advantages of really all of these types of design studies, but unfortunately that's what we have to work with. Next slide. So part of what I do at VAMS is really looking at the safety of medications as well as vaccines using 3 types of studies. We have the large retrospective data study coming out of the Harvard Pregnancy Research Group, case control, which is now coming out of the CDC, and prospective cohort. And we really try to work together with these groups, looking at specific medicines as well as vaccines, and use all 3 types of studies to hopefully increase increase the information and really provide more of a cohesive amount of information as well. Next slide. So moving into short-acting beta agonists. There is substantial reassuring data from larger retrospective and prospective cohorts. From case controls, there have been some reports of increased specific malformations, but again, severity may have confounded the results. Albuterol was first patented in 1972, and it's still one of the most commonly used asthma medicines. But despite being on the market for so long, there still is a lack of evidence regarding its safety. But obviously, in this conversation with your patient, the benefits certainly outweigh the potential risks of using the medication and preventing a potential exacerbation. Next slide. Inhaled corticosteroids, again, are the cornerstone of managing asthma, certainly persistent asthma. There is substantial reassuring data for low to medium dose inhaled steroid therapy, but there may be possible associations with high dose inhaled steroids. And this comes from a large retrospective database in Canada. But again, this may be confounded by severity. Budesonide and fluticasone are the most steady, but there's really no data to suggest that other inhaled steroids are less safe. At this point, the recommendation is adverse outcomes may be associated with higher doses of inhaled steroids, so they have to be studied further because this could be a confounding. This could be confounding by severity. Budesonide or fluticasone should be considered if you're considering starting an inhaled steroid during pregnancy. But obviously, if someone is well controlled on another inhaled steroid prior to pregnancy, one could argue that you could just continue that during pregnancy rather than switching. Next slide. In terms of long-acting beta agonists, one study showed that the risk of major malformations was similar with a long-acting beta agonist plus inhaled steroid combination versus an inhaled corticosteroid at higher doses alone. There have been reports of increased risk of specific malformations, but again, this could be confounded by severity. Outcomes, including low birth weight, preterm birth, and small for gestational age, were found to be similar between salmeterol and formoterol. So recommendations at this point, because long-acting beta agonists are prescribed for more severe symptoms, severity can be a confounder in these studies, which need to be investigated. And when you are kind of deciding between salmeterol versus formoterol, that can be really based on non-pregnancy considerations. So I think that you could go either way, and certainly if someone is tolerating a combination therapy prior to pregnancy, you could continue that during pregnancy. Next slide. In terms of oral steroids, cohort studies have reported associations between its use as well in the outcomes, including preeclampsia, preterm delivery, preterm birth, low birth weight. But again, because these are used in situations such as asthma exacerbations or asthma severity, there is a confounding variable there that needs to be addressed. There have been conflicting data regarding the association of oral steroids and cleft lip palate. So the recommendation is that these outcomes could be outweighed by the potential risks of severe asthma exacerbation, which can by itself, being untreated, lead to maternal or fetal mortality. So oral steroids are frequently used during asthma exacerbation when patients are already on other medicines. So even having the other medications could be a confounding variable as well. But again, weighing the benefit and risk of an untreated exacerbation, one would probably err on using oral steroids for a short period of time. Next slide. Most data is available for the leukotriene antagonist for montelukast. There is reassuring data regarding its use in congenital malformation in over 1,000 exposed infants. So one could argue that continuing it during pregnancy, especially if they responded prior to pregnancy, is a reasonable action. Next slide. Now we're going to move into kind of the more severe asthmatics. You're looking at kind of the GINA guidelines. We're at the GINA at the step 5, where we're considering biologics. I'm going to provide kind of the available data on biologics, since we all use them and are using them more frequently, and we're seeing more pregnant patients receiving them over time as they become available. Next slide. So all of the biologics are derivatives of IgG in different structure. IG1 has a half-life of roughly 21 days. And most monoclonal antibodies have the Fc domain of the IgG1. Dupilumab and rislizumab have the IgG4 antibody framework. Next slide. Omalizumab, which was approved in 2003, is the only biologic with safety data during pregnancy at this point. And I don't need to kind of talk to you about how omalizumab works, but it is obviously approved for moderate to severe allergic asthma, nasal polyps, chronic urticaria. Next slide. In terms of the available safety data, the animal data is reassuring. Lactation data is available based on the EXPECT registry, which I'll go into. 80% of the infants were exposed to omalizumab through breast milk, and the infection rate was not increased in infants exposed to it through breastfeeding. Next slide. Before I get into the EXPECT study, I just want to highlight, I think many of you know that in 2015, the pregnancy category letter system was removed. And so 8.1 pregnancy in the package insert is where you're going to find all of your information in terms of availability of a registry, a risk summary of any available safety data, clinical considerations as well, and any animal, specific animal and human data if the human data is available. Next slide. This is the 8.1 pregnancy section for omalizumab. So you can see here that you have kind of an overall risk summary. that highlights how omalizumab works and any available human data just kind of given to you right up front. Then there's clinical considerations, which include kind of the risk of untreated asthma during pregnancy and really highlighting that. Then any human data that's available for that particular medication, and in this case, the EXPECT study is reviewed in more specifics, and then the animal data. So that's where you're going to really get most of your information for any medication during pregnancy. So it's really upon us to kind of dive into this information, come up with a conclusion that we can then present to the patient, rather than in the past having kind of a letter category system, which was, I mean, obviously easier for us to go through medications and come up with information. So this is much more labor intensive for us, but all the data is here. Next slide. So the EXPECT study for, this was a registry and a single arm observational study that ran from 2006 to 2018, really following, it was a post-marketing surveillance study following pregnancy outcomes in women that were exposed to omalizumab. So we looked at outcomes including preterm birth, small for gestational age, low birth weight, malformations. The final data was in almost 250 pregnant women, and we were able to compare it to a disease-matched comparator population of pregnant women so that had moderate to severe asthma that were not exposed to omalizumab. And there was really no significant difference between the groups in terms of rate of congenital malformations. And then I reviewed the lactation study as well. So this is kind of the only biologic that has, published safety data. But more is coming regarding the others, and I'll get into those as well. In terms of urticaria, there have been multiple case reports of women who were exposed to omalizumab through pregnancy with no significant complications. From the EXPECT study, 30 patients were exposed who had urticaria, and data was comparable to that of patients with asthma in terms of outcomes. Next slide. So let's move into the biologics treating eosinophilic asthma. Next slide. So I'll be presenting the safety data that's available from epolizumab, benralizumab, and reslizumab. Reslizumab, next slide. It is approved for severe eosinophilic asthma. Next slide. Really no human data. I don't believe the pregnancy registry is still open. There are animal studies which are largely reassuring, and the lactation studies are reassuring as well. Next slide. In terms of mepolizumab, half-life of 2 days with a washout of 100 days to 3 months, multiple indications at this point. Next slide. There is a pregnancy registry, currently no human data, but I believe the registry is still enrolling for a short period of time. So if you have any patients, please visit the Mother to Baby website. In fact, you might want to keep this in your files and check periodically if you have questions about any biologics that may be registering patients, because Mother to Baby is one of the largest organizations doing that here in the United States. So it's worth kind of keeping that on hand, and they will have a lot of information in regards to the safety of medications during pregnancy. And they do have a telephone database for your patients to call if they have any questions. The animal data is largely reassuring, no human data on lactation, but some animal data. New slide. In terms of what's out there case report wise, there was a case report of a woman treated for severe asthma, started prior to conception and through pregnancy, and delivered a healthy baby. Next slide. So I can share from Mother to Baby the pregnancy registry, kind of the enrollment data from 2016 to 2022. There were 23 patients enrolled into the Nucala exposed cohort. And I think as of September 2023, this number has not changed too much. So very low numbers, clearly likely not enough to really be able to make any firm conclusions in regards to safety, which just highlights not a lot of patients who are pregnant are receiving biologics. Next slide. Benralizumab, again, approved for eosinophilic asthma. Next slide. No human data, but a pregnancy registry, again, through mother to baby, is still enrolling for a short period of time. Animal data is reassuring, no lactation data, and again, very, I believe, small numbers in terms of current enrollment, which is a real problem for us in terms of being able to supply safety information for these medicines. Next slide. So in terms of what's available on case reports, there was an unexpected pregnancy while on benralizumab, and this was to treat HES with eosinophilic gastrointestinal disease. This baby was born late preterm with 0 eosinophils, which persisted until 7 months, but no sick visits through the first year of birth, and this infant was not breastfed. Next slide. Dupilumab, again, kind of moving on to a different type of function and monoclonal antibody, multiple conditions and new conditions to be evaluated in the future as well. Next slide. So there have been case reports of safety of dupilumab during pregnancy. There is a registry with mother to baby that is continuing to enroll through November 2023. So if you have any patients, I encourage you to enroll them or have them self-enroll. Animal data is reassuring for dupilumab use during pregnancy, and no lactation data is available. Multiple case reports and one report from the World Health Organization. Most were prescribed for atopic dermatitis. Some described continuous use from conception to delivery. None were breastfed. No teratogenic effects were reported. All infants were described as healthy, and of those that report, all babies were born term. Next slide. In terms of the pregnancy registry, so this is a North American-based registry through Otis and Mother to Baby, designed to monitor pregnancy and infant outcomes. So recruitment began in October 2018. I'm sorry, it will continue through October 2023, not November. The goal of 500 participants in the cohort study, which include 200 exposed, 200 disease matched comparator, and 100 healthy comparator. So between 2018 and November 2022, 354 participants were enrolled, 144 dupilumab exposed. I think they're not going to have any problem by October 2023 to have met their goal. So hopefully this in 2024, we will get some very important information regarding the safety of dupilumab during pregnancy. New slide. Tezepelumab is the new biologic, but unfortunately not too much information is available. New slide. Animal data is reassuring. Lactation data is also reassuring. There is no registry that I know of at this point that is enrolling. But again, worthwhile checking mother to baby. New slide. We're going to head into other allergic diseases, with the first being allergic rhinitis. So similar to asthma, rhinitis can actually change during pregnancy. It can worsen, it can improve, it can remain the same. And sinusitis is the same along with this. It's important to really understand and be able to differentiate between pregnancy rhinitis and allergic rhinitis if you can. Pregnancy rhinitis is due to hyperemia and edema of the nasal mucosa. It tends to be more congestion symptoms. Having allergic rhinitis during pregnancy does not put a mother or baby at an increased risk for perinatal complications. I will note that we rarely do skin testing during pregnancy and kind of more rely on RAS testing or specific IgE testing to common aeroallergens. And the exception, though, with this would be potentially skin testing and a penicillin, but that's a whole other talk. Next slide. So obviously, trigger avoidance is important in the pregnant as well as non-pregnant patient. New slide. In terms of management, loratadine and cetirizine have the most data behind it, so they would be the antihistamines of choice when recommending medications for allergic rhinitis during pregnancy. Intranasal antihistamines don't have a lot of data, so you would consider avoiding these medications unless absolutely essential and used in short bursts. Typically, we avoid decongestants in the first trimester, but pseudoephedrine would be the decongestant of choice if essential. Budesonide, fluticasone, or mometasone if starting an intranasal steroid during pregnancy, but others may be continued if effective. There was a paper in the JCI with a possible association of triamcinolone nasal spray with certain respiratory defects, congenital malformations. So that's why these three would be kind of the first choice. New slide. We generally don't start immunotherapy or build up during pregnancy, but if a patient is on maintenance doses, you can certainly consider continuing, and we do at Scripps. And there is some data in terms of the safety of sublingual immunotherapy in one small study, but obviously more studies are needed. You know, it obviously becomes a conversation with a patient who's on immunotherapy that obviously an adverse reaction can occur at any point during treatment, whether it be during the buildup phase or maintenance phase. So having that dialogue is also very important. New slide. So anaphylaxis during pregnancy happens, and it's estimated to be about 2.7 cases per 100,000 pregnancies. It has been associated with adverse outcomes, including maternal and fetal death, and may be associated with neurologic abnormalities in the infant. Antibiotics are interestingly the most frequent cause of anaphylaxis, but the fetus is relatively protected from anaphylaxis. Maternal hypoxia or hypotension can lead to fetal distress, and it may require cesarean delivery to avoid fetal hypoxemia. But the treatment is still the same as in non-pregnant patients: epinephrine, IV fluids, and steroids. New slide. Epinephrine is associated with birth defects in some studies, but may be confounded by indication. And it has the potential to reduce uroplacental blood flow, but obviously, since there's no effective substitute, you always have to weigh the benefit and risk of delaying epinephrine during an anaphylactic episode. New slide. There are other aspects of anaphylaxis treatment. You want to position the patient on her left side to prevent compression of the vessels to the fetus. You want to supply high flow oxygen to support fetal oxygenation. You want to maintain blood pressure. You want to obviously have fetal heart rate monitoring, and then use other medications such as steroids and antihistamines. New slide. So in terms of urticaria and angioedema, there was one observational studies of patients with a small study of patients with idiopathic urticaria. 4 got worse, 3 got better, 9 had no change. So again, a variability was seen during pregnancy that may be seen as well in our patients. Again, urticaria has not been shown to be associated with adverse outcomes during pregnancy. There really are not a lot of data in terms of these specific medications used specifically for urticaria and angioedema, but I hope that you can translate their use in other conditions such as allergic rhinitis and choose those medications as well as its use for asthma, and then translate that safety data to urticaria. Again, cetirizine and loratadine being first choice. If not controlled, you can consider other medications such as hydroxyzine, and if severe enough, you could consider omalizumab therapy. Next slide. Hereditary angioedema. There was one study that reported an increase in the rates of spontaneous abortions and preterm labor in women with HAE compared to healthy relatives. The course of HAE is variable during pregnancy. One study found that the first trimester patients were more symptomatic. Interestingly, HAE attacks are rare during labor, and that's also true for asthma exacerbations as well. But in HAE, attacks may increase in the postpartum time as well as during breastfeeding. Next slide. There is reassuring data on the use of human plasma-derived C1 esterase inhibitor during pregnancy and some retrospective cohort data as well as case reports. But obviously there's no controlled studies that I can report. Also some case reports on successful use of icatibant during pregnancy. But unfortunately, we don't really have a lot of human data regarding these medicines that are available. Next slide. These are considered the allergic eruptions of pregnancy, which include prurigo pregnancy, pruritic folliculitis of pregnancy, and atopic dermatitis. This term was developed in 2006 to encompass allergic eruptions. This was really based on histopathologic overlap. There is some kind of argument whether these all should be grouped together, but I'm really going to focus on atopic dermatitis and its treatment. It actually makes up to 50% of all pregnancy dermatoses. Obviously, hormones can lead to increased vascularity, edema, stretching that can increase susceptibility to allergens. There is variability of atopic dermatitis during pregnancy, similar to other conditions where 30 to 40% of patients appear to worsen during pregnancy. Flares usually occur by 20 weeks gestation. But there's really no data to associate atopic dermatitis with adverse outcomes, but obviously it can affect quality of life. Next slide. We don't have a lot of data on calcineurin inhibitors for atopic dermatitis, as well as the crisaborole that we use. You typically want to avoid mycophenolate, azathioprine, and methotrexate, but that could be argued if symptoms are severe enough. UVB therapy appears to be safe, and then obviously antihistamines and prednisone based on previously reviewed data for allergic rhinitis and asthma. Next slide. From the UK, this was a database study of over 80,000 patients. And there was a previously reported association with oral clefts, but that was not confirmed. No significant adverse outcomes were noted for fetal death or preterm birth, but there was an increased risk of fetal growth restriction in those patients receiving mild to moderate potency preparations. So one could take away that obviously you want to use the lowest potency as possible to control symptoms, or use moderate to high doses for a short period of time. Dupilumab, again, we reviewed the data, no published human data yet, but hopefully soon. Next slide, and I think this is probably one of the most important, is really having the dialogue with your patients who have allergic disease during pregnancy. Preconception is actually the best time to start the dialogue, right? If we can start talking to our patients in the family planning stages, we have more of an impact. So preconception counseling, asking kind of childbearing aged women about family planning and having that dialogue early is better, especially in our asthmatic patients. Really talking and being really open about adverse outcomes and the benefit and risk of treatment. And then assessment and monitoring. I mean, download the Breathe for Baby toolkit. Also visit the site. It has multiple downloadables that you can have kind of available to yourself and your patients in regards to the safety of medicines, including biologics, and really having that available because that will be really important. We're not doing as good a job as we can in terms of assessing and monitoring. And I didn't mention that in our patients that we follow with asthma during pregnancy, we follow on a monthly basis, and we hit all of the major important indicators like risk factors, inhaler technique, spirometry, and maybe even fractional exhaled nitric oxide levels. So we do all that monitoring on a monthly basis, and we assess asthma plan and kind of revisit that, as well as do the pregnancy ACT. And then reviewing medications and adherence. That's the last part that is very, very important. Patients may not tell you that they're taking medications, and just kind of asking them and really answering their questions and their concerns is going to be the most important in this population of patients. So that's it. If there's any questions.